Hello, my name is Dr. Kristin Robinson. I am currently a breast imager at the Mayo Clinic in Florida. Today I'm going to talk with you about a radiology consultation clinic that we opened at the Mayo Clinic in Arizona. The title of my presentation is Dense Breast Consultation Clinic, a Single Institution Experience of a Patient-Centered Breast Imaging Clinic. The authors have no disclosures. To provide some background on why we opened this clinic, the motive for opening such a clinic was really sparked by the breast density reporting laws that many states have enacted over the past decade. Arizona in particular enacted their breast density reporting law in 2014, and over the course of the years, as women and providers started getting these breast density statements, we realized that radiologists could play a role in offering information to patients about breast density and supplemental screening exams. Additionally, as a breast imager, we all want to increase our breast cancer detection rate in patients, and particularly those in dense breast tissue, since we know that mammographic sensitivity is decreased for these women. So as I mentioned before, the need really arose as density reporting laws increased, and we recognized that the verbiage usually read something like, you have dense breast tissue, talk about supplemental screening with your provider. We recognize that providers have a lot to talk about with patients on a daily basis or during their clinical visit. And some of the providers, particularly primary care or mid-level providers, may not be as up-to-date or knowledgeable about what supplemental screening exams are out there, what a patient might benefit from, and the pros and cons of having each type of test. So what we decided to do as a solution was to establish a breast radiologist-run consultation clinic where we would review these topics formally with patients. During the consultations, we reviewed breast density as well as supplemental screening exams. We also developed a survey so that we could really assess were patients learning anything, what knowledge they had gained, and their overall satisfaction. As far as the consultation itself, we developed a PowerPoint presentation with a multidisciplinary team of providers, including breast imagers and our women's health internal medicine providers. That way we knew we were being consistent from visit to visit, as well as consistent with what our referring providers and primary care folks had been or were telling patients about breast density and supplemental screening. We really wanted to make sure we had a cohesive front as an institution about this. Topics we reviewed in the presentation included breast density reporting laws, what is breast density, its implications for cancer risk and masking, and also supplemental screening exams that are out there and which a patient might benefit from specifically. In order to perform these consultations, we first had to build an infrastructure within our EMR. This meant building a clinic calendar that would allow us to actually go into a patient encounter, document, and bill. So most radiologists, at least specifically at our institution, we see a completely different side of the electronic medical record than the clinical providers do. So as it stood when we first embarked on this journey, we had no way of accessing a patient chart in a way that would let us do any of the things needed to really have a formal consultation. We knew that obviously our interventional radiology colleagues had clinics, and we tried to just have that same infrastructure put into a clinic calendar for us to be able to see patients in this way. As far as the consultations, we actually held them in our breast clinic, so in the same exam rooms that the surgical oncologists use, the oncologist, and the women's health providers. The visits most of the time take about 45 minutes, sometimes less, sometimes a little more, depending on patient questions and the complexity of their imaging and breast history. We book them in 1-hour slots, so that way we can research the patient, before she comes in the room. we can perform the visit and the consultation and then do the documenting with the clinic note and the billing all within that hour slot. During the consultation, that presentation that I mentioned we had developed is gone through slide by slide, and we also review each patient's individual mammogram so that she can really see visually where her breast density is in the breast density categories. The patient surveys we developed were IRB approved. We developed both a pre and post questionnaire so that we could compare a patient's knowledge before and after the visit. Incomplete questionnaires were excluded from survey analysis. Topics were generally put into two categories. We had knowledge-based questions to objectively see what the patient had learned. Then we had more subjective questions that evaluated her satisfaction with the visit. The patient surveys were distributed to the patient by the radiologist performing the visit that day. The pre-consultation questionnaire was completed immediately prior to the visit commencing, after the patient had agreed to and signed consent for participation in this study portion of the visit. And the post-consultation was filled out immediately after the visit and collected actually before the patient even left for the appointment. That way we ensured we had complete questionnaires and did not have to worry about them being mailed in or sent in some other way. We had our results analyzed with comparative statistical analyses, really looking for differences between the pre and post questionnaires. When building a clinic like this, there are many logistical considerations. So the first is building the clinic. Determining, aside from just the IT portion where you really need to work with your counterparts to actually have a clinic built in your EMR, you then have to decide who is going to give these consultations. Will it be staff radiologists, residents, fellows, mid-level providers? Currently at the Mayo Clinic in Arizona, it's our staff breast imagers who predominantly give the visits, and we have fellow participation when possible. Where the consult's going to take place, as I mentioned, we had ours in a more formal setting in the breast clinic exam rooms, but depending on the space that you have, you may need to get creative on where these take place. And how to document. So again, this kind of really plays into the EMR setting, but it's important that you have a functioning clinical aspect to your EMR, that you can do your notes, you can order screening exams, you can order whatever follow-up the patient may need, and also be able to bill through that setting. As far as the consultation itself, who's going to order these? Well, what we ended up doing, and the workflow that has been successful, is the radiologist essentially identifies patients who might be appropriate for coming to this clinic and makes note of it on the screening mammogram. So currently in the practice, when a woman presents for a screening mammogram, the mammography technologists go through an abbreviated risk assessment, and if a patient is found to have a risk greater than 20%, she is actually recommended to be seen in our high-risk clinic and not the dense breast clinic. But if her risk percentage is lower than 20% and she has dense breast tissue, the radiologist will place a statement on the mammogram recommending that she be considered for a consultation in the dense breast clinic, or at least some type of supplemental imaging, and that way the referring provider can see this recommendation, know that we have said this patient is probably appropriate, and the provider can reach out to the patient and ask if she is interested in having a consult, and then formally ordering one. As far as who orders the supplemental screening exams and follows up with the patients on the results, we really wanted to develop a streamlined process in where a patient could schedule a supplemental screening exam on the day that we saw her if she wanted to. So we thought it was important for the radiologist to actually be able to order the supplemental screening exam. And in our EMR, when we order one, we are able to CC the referring provider on the results. So that way, when the results come in, whether it's a month from the time of the visit or 6 months from the time of the visit, the referring provider still gets those results he or she knows what was done and can follow up with the patient to make sure that follow-up is appropriate. Having patients to be seen in the consultations is obviously a crucial part in having a successful clinic. So we ended up recruiting patients really by actively engaging our referring providers. Initially, when we opened the clinic, we wanted to have a select number of providers be able to order the consultations so that we knew the workflow was working adequately. We could go back and forth with them individually and make sure that things were going as expected. And we wanted to make sure the patients who were being referred were appropriate. So the initial providers that had access to ordering a visit were basically our breast clinic providers, so some of the surgical oncologists, certainly the women's health providers, and the oncologists. But we weren't really getting that many referrals, and we recognized that it's because, these providers in particular at our institution were really the ones who were most able and apt to have these conversations about breast density, high risk, supplemental screening, etc. So we decided to switch gears and open up the consultations to be ordered from basically any provider who orders screening mammograms. So we engaged these providers by sending out individual emails to just about all of them, letting them know that the consultation clinic was up and running, giving specific examples and step-by-step guides on how to order this within our EMR. And after that, we really started filling the clinic to capacity. As I mentioned previously, when a woman is recognized to have dense breast tissue on her screening mammogram, the radiologist will place a statement that the patient has dense breast tissue, and she may benefit from a dense breast clinic consultation or a supplemental screening with MBI. That's typically the exam of choice at our institution. And so this prompts the provider to see this, talk with the patient, and order the consultation from there. We also put a flyer at the patient check-in desk so that when she came for her mammogram, if she knew she had dense breast tissue from past mammograms or past providers telling her this, she could see that there was now a service to talk with her more about it, and that she just had to ask her provider and they could make a referral on her behalf. So once we really started recruiting patients using all three of these ways, again, our clinic filled up to capacity very quickly and continues to book out weeks in advance. At this point, some of you may be saying, well, this is all well and good, but you mentioned billing. How do we bill? Can we bill? So the good news is these visits are reimbursable through the patient's insurance. To date, we have had no denials from government nor private payers. When we look at our RVU data, on average, these consultations provide about 2.8 RVUs per visit. So if you do the math and you look at the RVU data from a day of reading screening mammograms, diagnostic mammograms, etc., this obviously brings in a lot less revenue, but our goal with opening this clinic was never really revenue boosting. We really wanted to have it be practice boosting, and it certainly has been. So our patients are very happy with the service that they can have. Our referring providers are ecstatic that they don't have to have these conversations anymore. And really, in order to make this clinic something that was viable over many years, we did want to make sure it was reimbursable. Again, however, something that you have to really factor into your overall practice and determine how you're going to have your radiologist come off schedule in order to perform these consults. But even though it isn't going to bring in as much revenue as a day in the reading room, it really is an incredible service that has been very well received from patients and providers at our institution. Here is an example of a slide from the presentation that is reviewed with each patient. This slide covers the breast density categories, showing that there are 4, and showing what they are, what the mammogram appearance is, and what percentage of women fall into them. Immediately after showing this, I would typically switch to the patient's individual mammogram and show her where she falls on the spectrum of categories. The feedback I often got was this might have been probably the most eye-opening slide for patients, just really for the first time not having breast density be such an abstract concept in their minds, but really something they could understand visually. In addition to this mammographic example, we also showed examples of small cancers detected in kind of scattered tissue versus big cancers, which unfortunately are masked in the dense breast tissue, and that also I think really visually hits home as to the message that we're trying to give about breast density, mammographic sensitivity, and why we really want patients to consider supplemental screening. Here is an example slide from the presentation where we discuss one of the supplemental screening exams in detail. So the supplemental screening exams that we review are whole breast ultrasound, molecular breast imaging, MRI, and contrast-enhanced mammography. For each of these, we talk about what the exam is, if there is an injection or not, is there radiation, and how much, and really the pros and cons. So in the pros and cons conversation, we talk about essentially false positive rates, possibly the need for more biopsies. We talk about the increased cancer detection of that particular supplemental screening exam. And ultimately, at our institution, we typically recommend molecular breast imaging for women who have dense breast tissue. But again, we do go over all of the different imaging modalities out there so that if a patient, does a Google search or on her own or hears that a family member or a friend had a particular test, she is a bit more armed with the knowledge of what that test is. For each of the supplemental screening exam modalities, we give examples of how the patient's mammogram looked and a cancer that was detected on the supplemental screening exam. So, for example, this is a woman who mammographically has heterogeneously dense breast tissue. The read on this was a BI-RADS 1. She presented several months later for a supplemental screening test with molecular breast imaging, and you can see that there is focal uptake in the upper portion of her right breast. This did correspond to an 8 millimeter cancer seen with an ultrasound, a targeted ultrasound, and again you can really see how this cancer is mammographically occult. So showing patients these examples, again, this is not a large cancer, this is a small one, but it's something that, still can be treated now with a lumpectomy and is early stage, small, and that's where we really want to find breast cancer. So when you show patients this, it really helps to make them understand that we want to do the best we can as breast imagers to find breast cancer, some of the limitations that we have, and how supplemental screening can really help. I'll now discuss some of our survey results and data. We collected surveys from February 2019 to September 2019. During that time, 140 consultations were performed, with 104 completed questionnaires returned. On average, patients were 57 years old from this cohort, and about 9% actually did have a personal history of breast cancer. Here are some examples of the knowledge-based type questions that we asked. So one question we asked is, what is a radiologist? And before the consultation, 84% of women answered this question correctly. Afterwards, 92% did, which was a statistically significant increase in that knowledge from that question. We also asked them how many breast density categories are there. Pre-consultation, only 8% got this correct, and afterwards 92% did. We asked them questions about dense breast tissue and its implications regarding cancer risk, mammographic sensitivity, and overall some knowledge about cancer detection rates with supplemental screening exams compared to mammograms. Collectively, before the consultation, 60% of patients got these questions correct, and 92% did on the post questionnaire. So we saw an increase that was statistically significant in the objective knowledge-based questions before and after the consultation was performed. We also asked knowledge-based questions specifically about each supplemental screening exam. And you can see on this graph that the pre-consult number of correct answers is the red bar, and the post-consult number of correct answers is the blue bar. So for each question asked about the various supplemental screening exams, there was a statistically significant increase in the knowledge about that exam between the pre and post-consult visit. In addition to objective knowledge-based questions, we asked them a number of questions regarding their perceived knowledge and patient satisfaction. So this graph shows the perceived patient knowledge of various supplemental screening exams before and after the consultation. So for example, the red and pink bars indicate that before the consultation took place, that percentage of patients had no or very little knowledge about a particular supplemental screening exam. The blue bars show that some knowledge or a lot of knowledge the patient felt like she had of that particular supplemental screening exam. And what you can see on this example for MRI is that between the pre-consultation visit and the post-consultation visit, at least some percent of patients initially felt they had no or very little knowledge, but afterwards, none of the patients felt that anymore, and all of them felt they had at least some or a lot of knowledge. And this same idea was represented with the MBI screening exam, contrast-enhanced mammogram, and whole breast ultrasound. So for each of these modalities, before the visit, at least some patients had no or very little knowledge of a particular exam in their opinion, and then afterwards, in their opinion, they all increased and felt like they had either some or a lot of knowledge about that exam. So we felt that this was very powerful because them feeling like they had that increased amount of knowledge would hopefully translate them to feeling like they could make better decisions about which test to undergo in the future or make a decision at all, and also just kind of advocate for their breast health. Other patient satisfaction questions were evaluated with their level of satisfaction and how much they agreed or disagreed with a certain statement. One of those statements included how useful they felt the information was that was discussed, and 89% really strongly agreed that the information was useful. 90% felt that the knowledge they gained would be useful to them in the future, and 92% said that after having this appointment, she had sufficient knowledge of supplemental screening exams available to her and could make an educated decision about which exam to undergo. You will see a small percent of the patients were very dissatisfied or strongly disagreed with the statements. In review of our survey data, this is actually all from the same patient. She felt like she had some memory issues, and so she felt that a better recap or summarization of the information presented to her would have helped her retain the information better, and she would have felt more fulfilled from the visit. So, to date, of the consultations that were performed and the surveys collected, 101 supplemental screening exams were recommended from the radiologist. Of those, 71 were performed to date. As you can see, the majority are MBI, and as I mentioned, that is because for women with dense breast tissue and when without other risk factors, MBI is our go-to screening exam for dense breast tissue. Of the supplemental screening exams that were performed, 70 of the 71 were given a BI-RADS 1 or 2, and one of the exams was given a BI-RADS 3 with a recommendation for follow-up ultrasound in 6 months. So no cancers detected yet, but we're working with very small numbers and do expect that the more supplemental screening exams performed, the more cancers we will detect. In conclusion, A radiologist-run consultation clinic is indeed feasible and can be very successful, but a multidisciplinary collaboration and approach is critical. Having your providers on board from the beginning, from the time of idea conception, is really, really important, not only to get their buy-in so they order the consults and can support you in that way, but to really make sure the information that you're distributing to patients is consistent with what they're saying, so that as an institution, you really represent yourselves as a whole network working for each patient individually. Radiologists can indeed provide a valuable service outside of the reading room, and I think a lot of us would agree that this is increasingly important, being visible to patients and making sure that they know we are specially trained physicians who are a really big and critical part of their daily care, even though they may not recognize it and never meet us. We also want to show that we can be valuable to referring providers and in turn third-party payers, so that we aren't commoditized. Specifically, the study portion and the survey portion that we did really demonstrates that patient knowledge of breast density and supplemental screening exams did significantly increase after undergoing a consultation, and a high patient satisfaction rate was seen for the vast majority of the women that we met with. Thank you all for viewing my presentation today. I would be very happy to answer any questions or discuss anything further with you. Please send me an email at robinson.kristin@mayo.edu, and I really need to give a special thanks to my colleagues in Arizona, particularly our division chair there, Dr. Vic Pizzatola, who was beyond instrumental in opening this clinic with me, and to our current providers there, our breast imagers, who continue to see the patients in this clinic and have really made it very successful.